Hello everyone, happy morning, a very good morning. I hope and I believe all of you are doing well. A quick note whether the audio visual is all good. Am I audible and visible? A quick note there. All right, that's great. So here in this session, we are going to quickly discuss, we are going to run through the important and the most expected MCQs for radiology in the upcoming FMG exam. Yes, a happy morning and a good morning to each one of you here. So before we start with the discussion of the questions, let me tell you about the NEET PG Vitals. That is the recorded classes that are, these are the recorded videos for the comprehensive preparation for your upcoming exams. Apart from that, the live classes will go on in the NEET PG Live Gold. But over and above that, we have these recorded classes, right? And this is called as NEET PG Vitals. You can take a separate subscription for the recorded classes, or you can take a combo subscription as well. We have the special launch price of 13.5K for the NEET PG Vitals, right? The recorded classes. These are the subjects that have already been recorded and are available. The rest of the subjects will be available in the next 1 to 2 months. And we have also started with the Rankers batch on the NEET PG Live platform. The Rankers batch we have started on January 10, where the 5 educators will cover the 19 subjects. You will have the test and discussion for all 19 subjects by Dr. Zena. Then we would be having a few subjects that I would be catering to in the month of February, the test and discussion for those, including anatomy, pharmacology, medicine, radiology, FMT, right? So, and we also have the previous year's toppers who would be coming in and mentoring you and guiding you in these last days. And then we have the module 3 where we have the most expected questions that we are going to discuss. And you can now take the 2-month subscription at around 7K. Okay. And this lecture is going to be around 30 to 40 minutes, Siddhant. Okay. And if you take the NEET PG combo subscription, combo is the live and the recorded subscription. For 1 year or more, you get the Unacademy notes, which are worth 7.5K free. And this is valid till January 16. So this is the various, the combination price that we have at around 19.5K. You get both the Vitals and the live classes ka subscription for 1 year. Okay, that is for 1 year. And we also have the Last Leap Marathon for NEET PG 23 that will be starting on January 20. And there will be rapid revision of all the 19 subjects that would be there. And if you take the subscription, you also get access to the ongoing test and discussions, the PYQ batches, which would be there. So the 2-month subscription is now at 7K. You can use the code Dr. Nikita while you are subscribing. So there would be rapid revision of all 19 subjects. Okay? And most important, do not miss out on this upcoming Sunday. We have the NEET PG 23 All India mock test, 22nd January at 9 a.m. And this is a free test. Yeah, right. You just need to register for it. There is no registration fees. And the top 50 rankers will get the mentorship sessions from the top educators. And there would be for the lucky 25 test takers, there would be free notes worth 7.5K. So this is on 22nd January at 9 a.m. Okay, so mark your dates, mark your calendar, and you can use the code Dr. Nikita while registering. So starting with the discussion here, we have included the most important MCQs. Yes, thank you, Gani, and wish you the same, and everyone here. Wish you a very happy Sankrant, Uttarayan, Bhogi, Lori. You know, there are different names to this festival all over India. So wish you all a very happy festive season. Right. So very, very important question here and a frequently asked question here. So what do we have here? This is the dilated esophagus that we are seeing. This is barium swallow, which is showing dilated esophagus. And what do we have is there is the narrowing in the distal end of the esophagus. There is the bird beak sign. Okay, that's the bird beak sign. So this is because of the contraction of the LES in achalasia cardia. Right, so this is the bird beak sign of achalasia that we are seeing here. Okay, this is the bird beak sign of achalasia, and achalasia is because of contracted LES, so we need to measure the pressure, so that we can do by manometry. Okay, that we can do by manometry. So the gold standard will be the manometry here. Endoscopy along with manometry is what we need to do here, right? And just a second. Yeah. 24 hours pH monitoring will be done for GERD. The reflux, acid reflux, is where we need to monitor the pH. So do not get confused between manometry and the 24 hours pH monitoring. This is achalasia. Where do we see the corkscrew appearance of the esophagus? Corkscrew esophagus is seen in diffuse esophageal spasm. Okay, that is seen with diffuse esophageal spasm. What surgery do we do for achalasia? What surgery do we do for achalasia? Remember HAL, Heller's myotomy. Actually, it is spelled as HE, but you can remember from the spelling, it is Heller's myotomy that is done. We can do the POEM surgery as well. The per-oral endoscopic myotomy is what also we can do. Okay, so that is about the first image here. Going on to the next one. Another very, very expected image and question in your exam. Peptic ulcer disease, a known patient. That history is very, very important. Absolutely right. It is giving IV fluids and emergency laparotomy. So what do we see here is there is free air under diaphragm that we are seeing here. So there is free air under the diaphragm. So the diagnosis here is pneumo peritoneum. Okay, this is pneumo peritoneum. What is the cause of pneumo peritoneum in this patient? Probably the peptic ulcer disease which has perforated. The peptic ulcer which has perforated, that has led to pneumo peritoneum. So the further management would be stabilizing the patient, IV fluids and emergency laparotomy. Remember that in perforation, barium is contraindicated. Do not do barium studies in perforation. Use iodinated contrast in perforation. Okay, use iodinated contrast in perforation. What X-ray is the best for perforation? It is chest X-ray erect. Okay, it is chest X-ray erect, which is the best X-ray view. Right, so remember that is for pneumoperitoneum. Okay, that's pneumoperitoneum. Very, very important image and a frequently asked image. Next one, another favorite with the examiners. Yeah, there's an ongoing radiology test and discussion course also that's going on the Plus. So we are discussing all the detailed MCQs there. Very good. So the history itself is enough here. A road traffic accident patient with low GCS, but the CT scan is normal. That tells you that the diagnosis is diffuse axonal injury. Okay, diffuse axonal injury. That would be the classical history that you would have a road traffic accident patient with worsening or low GCS. But when you do CT scan, the CT scan is normal. So what is the investigation of choice here? More sensitive is MRI. Okay, more sensitive is MRI. Now, MRI, what will you see on MRI and what sequence of MRI is the most sensitive? Very good. It is susceptibility weighted imaging. Okay, it is SWI which is the most sensitive. What is SWI? Susceptibility weighted imaging. Susceptibility weighted imaging, which is a good investigation to look for punctate hemorrhages in the brain. So when you do the MRI, right, so look at this MRI here. Those tiny black areas that we are seeing at the gray matter white matter junction, that is the grade 1 of diffuse axonal injury. This is a T2 star GRE sequence. which is another sequence which helps in identifying hemorrhages. So these are called as the black areas are called as the areas of blooming, right? So the areas of blooming at the gray matter white matter interface. This is suggestive of diffuse axonal injury. Those are the punctate hemorrhages. What MRI sequence is this, guys? First of all, this is CT or this is MRI? The first image that you are seeing here, is this CT or is this MRI? Very good. That's MRI. Because surrounding the brain, we see this black line which suggests the bone. Okay, the bone is black here. And what sequence of MRI is this? This is flare MRI. Okay, this is the flare MRI that we have, where you see the water is black and the white matter is also black. Okay, so this is a flare MRI. The white matter here, internal capsule is black. This is flare MRI. The hyper intense areas are the abnormal areas here. Okay, and when you do the GRE, it shows the areas of blooming. So this is diffuse axonal injury. What will be the history in PRESS? Posterior reversible encephalopathy syndrome, that is PRESS. What is generally the history in PRESS? Raised blood pressure. There is hypertension. Most likely this is common scenario given is a postpartum female with eclampsia, pre-eclampsia, eclampsia, and that is posterior reversible. Bilateral occipital lobes are affected. Okay. Next one here, this is a CT scan with the white bone, and we see those hyperdense areas in the CT scan. These are the punctate hemorrhages. Okay, so remember that it's not always that CT scan would be normal in TAI. It can show these acute hemorrhage. Always remember this point that acute hemorrhage is hyperdense on CT. Okay, acute hemorrhage is hyperdense on CT. Non-contrast CT is the investigation of choice for acute hemorrhage. Okay, so these hyperdense areas, they represent the acute punctate hemorrhages, right? Going on to the next one, what do we see here? What is the best answer here? C. The best answer here out of C and D, it is the large bore needle followed by the ICD. Okay, that's the better option if you compare the C and the D. And what is the diagnosis here? What's the image showing? So what are we seeing here? This is the visceral pleural line that we are seeing. And this entire thing, this is the black air. This is pneumothorax. Okay, this is pneumothorax. And this is the collapsed lung. The collapsed lung does not have air, the black air, and that is why it appears white. Okay, so this is right-sided pneumothorax. Even if you could not identify the image, the clue here, hyper-resonant note, is enough to make a diagnosis of pneumothorax, because hyper-resonant is seen when there is increased air. Okay, when there is increased air. So pneumothorax, first is the wide bore needle, and then whatever air is remaining, we can remove that by putting the ICD, right? By putting the IC drain. So that is pneumothorax. Is pneumothorax evaluation included in the FAST examination? Focused assessment with sonography for trauma. It's not included in FAST, but it is included in E-FAST, extended FAST, which has been extended to evaluate the thoracic cavity. Okay, so remember that pneumothorax is included in the extended FAST. Next question here, what are we seeing here in this image? Is it GCT, Is it aneurysmal bone cyst? Is it simple bone cyst? Or is it Brody's abscess? Very correct. This is GCT, giant cell tumor. Very, very important and a frequently asked image. First, tell me about GCT. Does it occur in the epiphysis, in the metaphysis, or in the diaphysis? Where does the GCT occur? GCT occurs in the epiphysis. Okay, GCT occurs in the epiphysis. So remember, we have E, C, G. Epiphyseal tumors are chondroblastoma and GCT. Okay, so the tumors involving the epiphysis, at least remember chondroblastoma and GCT. The difference is chondroblastomas. Blastomas generally occur in children. So this is unfused skeleton. This is a young patient. GCT, giant cell tumor, occurs in a giant person. That means it occurs with the fused skeleton. Okay, it occurs with the fused skeleton. Right? So remember that chondroblastoma is unfused and GCT is fused. That means it's an adult patient like in the 4th decade or so. So look at this image here. This is the fused skeleton here. Right? What do we see here? The bone is fused. There is no growth plate that we are seeing. And this is the epiphysis which is involved, reaching up to the bone surface, the articular surface, and it is eccentric, right? So remember that GCT is epiphysis, it is eccentric, and it is expansile lesion. Okay, it is expansile lesion. So this is giant cell tumor. What will be the treatment for GCT? Chemotherapy, radiotherapy, curettage. Remember, it is extended curettage. Okay, the curettage is the treatment. We don't do chemo or radiotherapy. Aneurysmal bone cyst, on the other hand, is similar to GCT. Aneurysm, remember aneurysm, like aneurysm is dilated, even that is expansile bone lesion like GCT. But the difference is opposite of GCT. GCT is epiphysis, this is metaphysis. GCT is giant, fused skeleton, this is unfused skeleton generally. So this is in the metaphysis with the unfused skeleton. Right? Simple bone cyst. Important finding in simple bone cyst is fallen leaf sign. Okay, that is the fallen leaf sign is seen in simple bone cyst, which is a unilocular cyst. When there is a fracture, the bone falls down. Okay, that's a fallen leaf sign. It's a young patient. Proximal humerus is very frequently affected. While Brody's abscess, subacute osteomyelitis, if this is the tibia, proximal tibia is a common site. You would see a lesion which is parallel, like along the bone axis, and it has the sclerotic margin. Okay, and it has the sclerotic margin. So that is Brody's abscess. Remember, Brody's abscess has sclerotic margin. Giant cell tumor generally has non-sclerotic margin. It does not have a sclerotic margin. Okay, so that is about these options here. And GCT, though this image does not show that, we can also see the soap bubble appearance in GCT. Okay, we can see the soap bubble appearance in GCT. Next one, this is a previously asked question in the NEET PG exam as well, so important. Bragg peak is seen with which of the following? So in radiotherapy, where do we see the Bragg peak? Very good. Bragg, remember Bragg BR is PR. Bragg BR is PR. So Bragg peak is seen with proton beam. Okay, it is seen with proton beam. Now, what is the Bragg peak? Okay, that's the advantage. That's the advantage with the proton beam when we do radiotherapy with proton beam. So what happens is when we use the proton beam for the radiation, it does not affect the normal superficial structures. We can target it only at the tumor, because with the proton beam what happens is initially the radiation dose is less, and when it reaches the tumor site, suddenly there's a peak at the tumor site of the radiation that it delivers. So all the radiation is being targeted at the tumor. So this is pencil beam like targeted therapy that we can give with proton beam. What happens with X-rays, gamma rays? The disadvantage with X-rays and gamma rays is that they have the majority peak in the superficial structures. This is the depth which is indicated. So there's a lot of skin erythema. The superficial structures are affected. Okay, so remember that is the Bragg peak which is seen with proton beam. So that is the advantage with proton beam. So therefore, in a child with brain tumor, we prefer using proton beam because it will target only at the tumor. The surrounding structures will not be the surrounding structures will not be affected. Okay, so that is about the Bragg peak. Going on to the next one, this is a previous FMG question. Which of the following investigations they work on the same principle? Which of the following investigations work on the same principle? Absolutely right. That is X-ray and CT because both of them use X-rays. X-ray investigation is basically called as radiography. Okay, radiography. Both of them use X-rays. CT is nothing but a three-dimensional X-ray. What do we have in CT? Is a rotating X-ray tube. Right. So both of them use X-rays and both of them have radiation exposure. CT has more because it's multiple X-ray images that we take at one time. So remember it's X-ray and CT. Ultrasound and MRI are the one which have no radiation exposure. Okay, ultrasound and MRI have no radiation exposure. Remember that point as well. Next one, which among the following is the most radiosensitive tumor? Very good. That's seminoma. Okay, that is seminoma. So remember the most radiosensitive tumors, it is Wilms. What is Wilms standing for? W Wilms is for Wilms. E is for Ewing's sarcoma. L is lymphoma. Okay, that is lymphoma. M is multiple myeloma. And S is seminoma. The testicular tumor which is radiosensitive is seminoma. Similarly, in female, the ovarian tumor which is sensitive is dysgerminoma, the counterpart of seminoma. Remember that seminoma is highly radiosensitive. Osteosarcoma is radio resistant. Okay, osteosarcoma is radio resistant. Remember that the M here in radiosensitive is multiple myeloma versus M for melanoma is highly radio resistant. Okay, melanoma is highly radio resistant. Okay. Next one, 50-year-old male presents with pain and distension, abdominal pain and distension. What is the diagnosis? Easy one here. This is sigmoid volvulus. Absolutely correct. So sigmoid volvulus, look at this coffee bean sign, right? The three lines, they are converging at this and that forms the coffee bean sign. Coffee bean sign is sigmoid volvulus. What else do we see here? There is the dilatation of the large bowel loops. Okay, there is this colonic dilatation that we are seeing. There's a dilatation of the large bowel loops. How do we know this is large bowel dilatation? By the presence of the haustration, which are the incomplete projections. So sigmoid volvulus will cause the proximal colonic dilatation, right? Where did we see in the recent short 150 class the coffee bean and nuclei? In the ovarian tumors? Which two ovarian tumors give the coffee bean and nuclei? Coffee. Who calls for coffee? Granny. Okay, so that is granulosa cell tumor. And the other one is the Brenner's. Okay, Granny calls Brenner for coffee. So remember, granulosa and Brenner's have the coffee bean nuclei. Next one, very, very frequently asked. A neonate presents with respiratory distress. What is the diagnosis? Correct. This is congenital diaphragmatic hernia, which has these bowel loops which are herniated into the left hemithorax. Left posterolateral is most common, the Bogdelic hernia. It's causing the mediastinal shift to the opposite side. This is congenital diaphragmatic hernia. What is contraindicated? The bag mask ventilation is contraindicated in these cases. Okay, the bag mask ventilation is contraindicated. This is congenital diaphragmatic hernia. Hyaline membrane disease would be a preterm baby with bilateral both the lungs white out. Transient tachypnea of newborn would be LSCS history with the presence of fluid in the fissures, or there would be pleural effusion, right? So that is the background history. In meconium aspiration syndrome, it's generally the post-term baby with patchy infiltrates, okay, with patchy infiltrates. That is meconium aspiration syndrome. Okay, so remember this is congenital diaphragmatic hernia. Next one, recent FMGE exam question. Where do we see popcorn calcification? Where do we see popcorn calcification? Popcorn calcification in the lung is seen in hamartoma. Remember this is like hamara, tumhara, popcorn. So this is hamara, tumhara, popcorn. That is hamartoma has popcorn calcification in the lung. In the breast, popcorn calcification is fibroadenoma. In the uterus pelvis X-ray, it is the fibroid. Again, this is a previously asked question which has a popcorn calcification. So pelvic X-ray was given with a lesion showing this stippled or popcorn calcification. So fibroid, uterine fibroid also shows the popcorn calcification. Okay. Next one, this is a recent NEET PG question as well. The sign shown is seen in all of the following except. Right. It is B, pleural effusion. Okay, that is B, that is pleural effusion. Why pleural effusion? What is the sign that we are seeing here? Okay, what sign are we seeing here? These we can see the black bronchi going through this white lung. So the sign which is shown here, this is the air bronchogram sign. Okay, this is the air bronchogram sign. Air bronchogram. As the term says, we see the bronchi containing air going through something, going through the white lung. Normally, why don't we see the air containing bronchi? Because air is black in the bronchi, air is black in the lungs. So both black, they get merged together. Now when the lung becomes white, the black bronchi going through it, they get a good contrast. So the prerequisite for the air bronchogram sign is the white lung parenchyma. So air bronchogram sign is present only in parenchymal pathologies, right? It is not present in extra parenchymal pathologies like pleural effusion. Pleural effusion is outside the lung. Similarly, it was not seen in mediastinal mass. Mediastinal mass is outside the lung parenchyma, right? So remember that consolidation, the lung becomes white. Pulmonary edema is of course a differential for consolidation, the lung becomes white. Hyaline membrane disease, we just now said it causes white out lungs. So you would see the black bronchi, right? So whatever causes the white lung with the patent bronchi containing air, that would give the air bronchogram sign. Remember that it's seen only in the parenchymal pathologies. It is not seen in extra parenchymal pathologies, right? Next one, this again is a previously asked FMG question. A patient presents with back pain. What is the diagnosis? Correct. This is Pott's spine. First, identify the investigation. Is this CT or is this MRI? What do you think? This is CT or this is MRI? Very good. That's MRI. Okay, this is not CT because the bone cortex is black. The lining of the bone is black. The lining of the bone is black. Okay. And what are we seeing is it only one vertebra which is affected? No. So this is one vertebra. This is second vertebra. This should be the third. And then you have the fourth vertebra here. Right. So we are seeing that two vertebra are affected with the intervening intervertebral disc also gone. So when you have the one vertebra, the second vertebra with the intervertebral disc also involved, we should always think of TB. When the intervertebral disc is involved, we should think of TB, right? Tuberculosis. So that is why this is Potts point. The most common type of TB is paradiscal TB, right? It's a paradiscal TB with the most common type of TB in the spine. Okay, so this is Potts spine, that is basically TB spine. What muscle can be involved? The abscess. It can form the abscess. So if this is the vertebra, we have the adjacent muscle here. So where can it go? The abscess can go into the psoas muscle, right? So this is also the question which was asked. Psoas में ये जा सकता है. Okay. Next one. Where do you see the T sign? T sign, see some confusion there. Do not make a mistake in this. Remember, T sign is the T, the most famous T wala, the chai wala in the country, our respected Prime Minister Modi ji. So remember, T is Modi, that is monochorionic diamniotic. Okay, so the T sign is seen in monochorionic, that's a single chorion, flat line, and diamniotic is the separating membrane, right? So that gives the T sign. Look at this one. You have the chorion here, right? This is the chorion here, the placenta which is here, and we have the separating membrane. So that is the T sign. Okay, so remember T sign. So that is Modi, monochorionic diamniotic, right? Lambda laddu, absolutely right. For the lambda sign, the mnemonic for the lambda sign is laddu. Okay, so remember that laddu, that is La, lambda sign is seen in D, that is dichorionic diamniotic. Okay, it is seen in dichorionic diamniotic. Next one, 30-year-old male presents with thunderclap headache. What is the first investigation to be done? "30-year-old male presents with thunderclap headache." The first investigation to be done is absolutely right. It's non-contrast CT. Okay, it's non-contrast CT. Now, thunderclap headache is suggestive of subarachnoid hemorrhage. What is the most common cause of subarachnoid hemorrhage? Trauma. What is the most common non-traumatic cause of subarachnoid hemorrhage? It is aneurysm rupture. This is also a question that has been asked in last NEET PG exam. Aneurysm rupture leads to subarachnoid hemorrhage. Subarachnoid hemorrhage means acute hemorrhage. Therefore, it is non-contrast CT, which is the most important investigation in subarachnoid hemorrhage, because it is acute hemorrhage, and acute hemorrhage appears hyperdense on non-contrast CT. So we can see that easily. If you see the subarachnoid hemorrhage in non-contrast CT, the next investigation would be CT angio to look for aneurysm. And because we want to see that which aneurysm has ruptured. So we will do CT angio to look for that. Remember, the first investigation is non-contrast CT. Any acute neurological presentation. Remember that the first investigation we generally do is NCCT because it's easily available and it is very quick. And so the first investigation is non-contrast CT. Next one, again one of the recent FMGE exam question. Which is the labeled heart chamber which is shown here is which of the following? Very good. That is the left atrium. Why is it the left atrium? Very correct. So this is the vertebra. Just in front of the vertebra, that means the posterior most chamber of the heart. That is the left atrium. Right? Left atrium is the posterior most chamber of the heart, which is the anterior most right ventricle. So anterior, this is going to be the sternum here. Sternum के just पीछे we have the right ventricle. So this is the heart that we are seeing normally placed. This is the left side of the patient. This is the right side of the patient. Right. So what are we seeing here? This is the left side and this is the right side. So left side में apex point कर रहा है. This is normal. This is the midline of the heart. Right. This is the midline of the heart. And we have the four chambers like this. This is the sternum here. This is the vertebra here. So just behind the sternum, we have the right ventricle. So whatever chambers are to our left hand side, हमारे left side में जो है, that's actually the patient का right side. So this is the right ventricle. So this is the right atrium. Okay, that's the right atrium. If that's the right atrium, this is the left atrium and this is the left ventricle. Okay, so remember that the chambers which are to our left side are actually the patient's right side. And what is this vessel here? What is this vessel here? It is going into the left atrium. What goes into the left atrium is the pulmonary vein. Okay, that's the pulmonary vein going into the left atrium. Okay? Clear with everyone? So that's about the chambers of the heart. Okay, that is about the chambers of the heart. Next one, what is this suggestive of? Is it normal, pleural effusion, pneumothorax, or lung laceration? It is pneumothorax. E fast. So what are we seeing here? This is the M mode of ultrasound. M mode is where we want to look for the movement. Now what do we see? Throughout the image here, what we are seeing is there are these flat lines. Okay, throughout the image it's a flat lines. In the lower part also there are those flat lines. Okay. So this where we do not see the movement of the lung, it's all flat. That is suggestive of pneumothorax. This is called as barcode sign or the stratosphere sign. Okay, this is called as barcode or stratosphere sign. Okay, if it is normal, what sign do we see in the normal lung? Normal lung is the seashore sign. Pneumothorax is the barcode or the stratosphere sign. So if you see in the normal seashore sign, we see the granular appearance, the motion of the lung, which looks like that sandy beach. If there is no motion of the lung, it is all the flat lines. So remember that normal is the seashore sign and pneumothorax is the barcode sign. Because in the seashore, we would see the in the lower part we would see the lung moving. So the concept is when we do the ultrasound, if there is no air, the sound waves reaching the lung is moving and it shows the movement. If there is pneumothorax, right now there is air. Now the ultrasound waves cannot pass through the air. So that is why the lung movement is not seen. So we would see the flat line. So remember that pneumothorax has barcode or stratosphere sign, all the flat lines. Normal is the seashore sign where we would see the movement. Right. Now coming to the, I believe this is the last slide here. What do we see here? Image A, image B and image C. Tell me the diagnosis of all the three and let me see who gets all the three right. I'm looking for the diagnosis of all three of these images. Right to the diagnosis for all the three. Yes, very close, Dharamveer, correct. But the first one is not the duplication. See, so good one here. First, now look at this image A. First of all, the image A is the one which is IVP. Okay, how do I know this is IVP? I see the contrast in the other kidney, I see the ureter, and I see the bladder as well. So this is an IVP image where we are seeing that there is hydronephrosis. Okay, but we are seeing only the hydronephrosis. We are not seeing the ureter, even on the delayed image. So this is PUJ obstruction, pelvic-ureteric junction obstruction. So when there is the pelvis, there is the ureter. If there is an obstruction here, there would be hydronephrosis without a hydroureter. Okay, so this is the PUJ obstruction. Okay, even in the delayed images, we will not see the contrast. This was asked in the recent exam. Second one here, this is a plain radiograph. It's not the IVP, right? And in the plain radiograph, what we are seeing is this is a calcification because this is a plain radiograph. It's not the contrast. And what do we see is the stone occupying the pelvis, right? So this is the staghorn calculus. So staghorn calculus on the plain X-ray. PUJ obstruction in the IVP delayed image as well. Next one again here, this is a plain radiograph. There's no contrast in the kidney. And we see the kidney which is calcified here. Okay, the lobular pattern, the entire parenchymal is calcified. This is called as putty kidney, which is seen with TB. White kidney, calcified kidney in TB. The parenchyma gets calcified. It's not just the pelvis, the staghorn jaisa nahi hai, parenchyma with the lobulated pattern. That is putty kidney, that is seen with tuberculosis. Okay, that's seen with tuberculosis. So these are the three important images that we should know, and they have been asked in the recent exams, right? So that was about the today's discussion for the most important questions and the images for the upcoming FMGE exam. We do hope that you get to see a lot of these images in the exam. These are the most important ones. I'm sorry, Dharamveer, what was your question if I missed on that? What was your query, Dharamveer? Yeah, please write down your queries if you have any. I'm waiting for your queries. Okay, the doubt about... all right, so I see the query here that is pneumomediastinum and pneumoperitoneum. Okay, pneumomediastinum and pneumoperitoneum. And the difference is, see, pneumomediastinum is the air surrounding the mediastinal structures. That's the trachea, the aorta, the heart. Peritoneum मतलब नीचे. ये diaphragm के ऊपर होगा, ये diaphragm के नीचे होगा. This will be air under diaphragm. This will be above the diaphragm surrounding the trachea, the aorta, the heart. Right? The terms itself are self-explanatory. है ना? तो ये air होगा below the diaphragm, ये air होगा above the diaphragm. Most common radiation used in radiology, if you're asking about radiotherapy, the most common used now is X-rays because we use LINAC, linear accelerator, which produces X-rays. Okay? All right, Anamika will be back with the KBMD sessions, just that my throat is a bit bad. So waiting for it to heal and recover from it, and then we would start with the KBMD sessions. Okay? All right. So thank you so much, everyone. Goodbye. Take care and keep studying, keep revising, and keep winning. Thank